Thank you. We're going to start off a little bit differently today. I'm not actually a doctor, or maybe I'm a Juris Doctorate because I'm got a JD, but more, as she mentioned, I'm in the public policy world, or I was, and now I'm a social entrepreneur. My name is Ilyse Stempler. I'm the COO of Open Development. We're a women-owned social venture that wants to improve population health by reimagining traditional service delivery models to strengthen quality care, improve efficiency, and achieve better results in health. So please bear with me while we take a short departure from talking exclusively about sort of breastfeeding to addressing maternal and neonatal mortality. I'm going to tell you a little bit about a project that we're doing in Liberia that helps support public-private partnership to provide care for women and newborns. So the Millennium Development Goals challenge the whole world to have maternal mortality and newborn mortality. And we recommitted to that with the Sustainable Development Goals and sort of doubled down. We're going to end preventable maternal and newborn deaths by 2030. And we have made incredible progress over the past decades, but it is starting to stall a bit now as we sort of picked off some of the low-hanging fruit, so to speak. We think to achieve this goal by 2030, we need to ensure that women and newborns can access quality care regardless of their ability to pay. So this is the challenge that brought us to Liberia, where we had been working for several years in the health space. So according to the Liberia DHS, the good news is breastfeeding is very common in the country. 97% of children aged 9 to 11 months are breastfed, and 82% aged 12 to 17 months. And child health in Liberia has significantly improved over the decades. But unfortunately, the maternal mortality rate is still the worst, among the worst in the world. It's like bottom 5. And often when mothers die in the hospital, their babies are abandoned there because there's nobody to breastfeed, and the fathers don't have the means of taking care of them. And so often people think that if you're in a city, that you have access to care, and that the urban areas aren't as important as sort of focusing on the last mile and reaching the people in the rural areas. But unfortunately, in Liberia, in their capital, where 1/3 of Liberians live, the statistics are just as bad in some ways, and some ways worse. So 38% of the reported neonatal deaths happen in the capital, and 1/4 of reported maternal deaths. So despite being close geographically to public facilities, many poor women lack meaningful access to the care there. So as Dr. Israel Ballard mentioned yesterday, this is really a systems failure. We can put more resources and more technology into it, but really we have to look at the system as a whole and make sure that incentives align with the resources. And we want to ensure that women get the right care at the right time, and so that we can sort of get them to the right facility that they need to be at. So to give a little bit of an illustration, I want to sort of have you imagine a woman that's in Montserrado County. So Sophie is a poor pregnant woman, and she sells vegetables on the side of the road. It will take her an entire day's salary to go to a public facility where she'll wait for over 4 hours before seeing a nurse, who often will tell her that they've run out of tests and she has to return another time. She might return next week, wait another several hours before being seen very briefly, and then sent to a pharmacy where she has to pay for drugs that are supposed to be for free. So lost time is lost money, and she's not going to return to that facility again. She will probably pay out of pocket for a traditional birth attendant who will come to her home, treat her with respect, and listen to her needs. But unfortunately, that may be on a dirt floor that's unsanitary, and if there's any problem, she won't be able to access quality care. If she's really lucky, her family and the community will pool resources so that she can go to a private facility. But that's going to be at significant long-term economic cost to her. So the problem is that many public health facilities are really just too overwhelmed to provide quality, respectful care that's free to all. Some governments are responding by trying to allocate more and more resources to the public health sector, even if they don't really have them. But this often does not address the underlying challenges with poor quality care. if you invest resources without the commensurate sort of accountability mechanisms that empower communities to demand quality care, you're often going to fail to improve quality. A couple of other statistics in Monrovia that are interesting, a lot of people don't know, is 80% of the facilities there are private. And because of heavy traffic, even in the capital, people can be hours away from a public facility. During Ebola, we also saw that the public health sector completely shut down and often closed all of their doors to pregnant women. This was actually the first time that the government tried to engage private facilities, and they paid them to open their doors just for private women and give them a discounted care. And it worked very well, but it was an emergency setting, and after the funding dried up, they had to end those partnerships. So in conversations that we've had with the government, they want to engage the entire health ecosystem, but they don't really know how. So we think that there's a real opportunity to create a public-private partnership and give women sort of the power of the purse in deciding where health core resources can be spent. The problem is, even if governments want to do that, the solutions and approaches that currently exist were built by and for wealthy countries. So big health insurance schemes, like a whole billing department. And so that doesn't really work for them. Or some countries have tried it, but it's a huge, these are middle income countries who have still a much larger budget than some of the poorest countries. So how do they choose sort of an approach that ensures good value for money? Can we sort of reimagine what the system looks like and use new technologies so that we don't have to sort of look at what grew up in some of, like, in the US, for example, which we all know has some problems, or in Europe. So we think there's an opportunity there, but given that there hasn't been a lot of engagement, you still need to build trust. So we want to find a solution that allows pregnant women to feel trust that they're going to get affordable, quality care, and then the private providers need to have trust that they're going to be paid, and sort of paid promptly. And the government needs to have trust that they're going to get good value for their money. So we've tried to build something in that sort of helps build trust among all of the partners at the same time, so that they have confidence to sort of be a part of the system. So what we sort of developed is a solution using new mobile technology, and it leverages e-payments that are now in existence, near-field communication, mobile applications, and data dashboards. And so it helps build the trust, but then strips out some of the business processes that have built up that actually don't contribute to care. So when an enrolled woman receives a token with near-field communication in it, so that's sort of like the Metro card. So it doesn't need connectivity, but it can now store more and more information. So this represents her e-birth record. And they're very cheap, and they're durable, and they can be reused. So that means that women in Liberia don't need to have a mobile phone. They can still participate in the program, and they will be given one of these. So when she presents herself to an accredited participating facility, the provider will see the card and know that she's part of the program. The healthcare provider can scan the chip on their phone, and a lot of them already have, most of the new Android phones all have near-field communication, and we met with a lot of providers, and they do already have a phone. And this opens up her e-birth record. And then there's an application on the phone that will walk the healthcare provider through a visit based on the country's clinical guidelines. So it'll remind them of what tests they should be ordering, what drugs they should provide. It will flag potential issues. And as she's going through the visit, she's entering in the test results and what she's observing. So she can sort of advise the women on what to do. She could find out if there is a condition that the woman has, should she be at that facility, or does she need to be referred to a higher level facility? So at the end of the visit, the healthcare provider then taps the NFC chip back to the phone, and it updates her record. So then the woman can leave, and she has her e-birth record. She can go to another facility if she didn't feel like she was treated properly, or if she moves and she's near another one. And that information also gets synced to the government server. So then the government has a dashboard of key health metrics and knows exactly what happened during that visit. And we will anonymize it so that there are privacy concerns. But they can see not just a CPT code, they can see the entire diagnosis, they can see what happened to her blood pressure over time and what that meant. It also will trigger an automatic e-payment back to the provider. It's based on the services rendered. So whatever happened during that visit will be associated with a payment, and that will be paid automatically. So instead of waiting 6 months for a claim to be reviewed and adjudicated, they will be paid promptly. And we can do flags based on the data that's there. There's flags that can sort of call back a payment or flag if there's sort of a trend that could signal fraud or could signal that there's an incidence of a new condition or disease that's happening in a certain area. And at the end of it, once the woman has given birth, and the program goes through 6 weeks postpartum, she can return the chip back and provide feedback on her experience. And so we're working with a local organization in Liberia that's also trying to do sort of a website of both accreditation of the various private providers, and then they'll work with us on reviews of what the people's experiences are. So the tool as a whole, we think, can be really valuable for governments because it allows them to enroll targeted beneficiaries. So they can figure out where do their resources need to be spent to really target the poorest and most vulnerable. It also establishes an e-birth record. It gives women more choice in where they can seek care and uses the utilization that's collected passively during the visit for several things. At the same time, we think for women, it'll encourage more women to go to A&C visits. It will make sure that they get the right care at the right time, get to the right facility that they need to, and go to more PNC visits, which in Liberia, very few women ever go to. So to make it a little bit more real, I put up a few of our screenshots to show sort of the different modules that we have. A&C, labor and delivery, PNC, and if they need to be sent to an emergency referral. So we have things for danger signs. And then the last one is sort of like a summary screen. So there's a lot more screens, but that's just to give you a flavor. And then, since we're talking about breastfeeding, I wanted to show you the breastfeeding guidance that we provide. That's based on the country's clinical guidelines. What we're trying to do is do a little bit of a balance between putting too much information in the application and the decision support to make sure that the midwives still want to use the tool. So we don't want to sort of have them scrolling through lots of screens while they're in a visit with the patient. At the same time, we want to provide information so that if they need guidance, if they need a reminder of what they're supposed to say, they have access to that. So we can have a discussion at the end if there's other messages that you think are really important to include. We're still working on it with the government. And then, so in terms of for us, for the next step is we're working on trying to do a feasibility test in Liberia and in another country that has a national health insurance scheme. And then we're looking to expand probably to other health conditions. We're very focused on maternal care, but at the same time, we know that if nurses are seeing a lot of different patients, we want to at least have a couple of other sort of key conditions so they get used to using the app, and we think then that will increase uptake. We're also looking at expanding not just private facilities. I think we think it's very important that you have an incentive that's sort of baked into it, but we can work in public facilities where countries have like a national health insurance scheme, or they've shifted from input-based financing to output-based financing. We're also in conversations with the Maternity Foundation that has a sort of a safe deliveries app. So as we mentioned, we don't want to put too much into the app so that people are focused on the app and not on their patient at the time, but in their downtime they can watch videos, instructional videos, vignettes, so that if a condition comes up during the delivery, they're more familiar with it and they can sort of practice on that. A little bit about our team. Other than open development, we work with D-Tree International, which is, they focused on e-decision support in Tanzania. And so they've built out this tool in a couple of different ways, and so we're building on the work that they've already done. And R4D, which is a health financing expert. So what we're also trying to do is not just pay whatever the private provider wants to charge, but to really figure out what kind of care we want to incentivize, what is the package of services that is most appropriate. And then we worked very closely with our Liberian colleagues to make sure that this worked in the context and it met their needs. These are a few of the nurses that helped us test the application and see if it would work. So I also just wanted to wrap up by telling you a little bit about the other innovations. We got our support from Saving Lives at Birth, and that is a partnership between USAID, the U.S. Agency for International Development, the UK's International Development Agency, Korea, Canada, NORAD, and the Gates Foundation. So they all pooled their resources to try to invest in innovations that would really accelerate maternal and newborn care. So they're focused on innovations that use technology, improve service delivery, or sort of the demand side, so women seeking good care. A flavor of a few of the other innovations, BEMPU has created sort of a bracelet for newborns that will signal to their mother if their temperature drops, and so that they can initiate kangaroo care. Lucky Ironfish is a little bit of looks like a metal fish, but you can put it in boiling water in your soups, and it will provide iron fortification. So it's a nutrition. And then Frio 2.0. So know that oxygen can be very important during the labor and delivery process, but often there's no electricity. So it uses solar power or running water to power it. So just a plug, there's a lot more innovations that are out there. In July 22nd, so next month, there's going to be a development exchange at USAID that will showcase all of the different innovations that they've been funding or that they're looking at. So it's pretty exciting, some of the other stuff people are doing. So that's it. So open to any questions. I know this is a little bit different than what you guys have been discussing.
Can you tell us a little bit about the motivation of the funders who were involved? I was surprised to see Korea in that space. What was their motivation and intention?
So this program has been going on for about 8 years now. So I'm not quite sure what the negotiations were for Korea. I think they provide some in-kind support. And actually what happens a lot of times is USAID has a much larger infrastructure to manage these types of projects. So some donors who are interested in the idea but can't run their own sort of grand challenge will give money to like a USAID or a consortium of partners.
What happens if she loses her card?
Loses her card. We get that every single time. So we're also working with an organization called Simprints, which is also another grantee, which uses biometrics to give women an identity, or not women, but just generally people an identity. And so we're talking to them so that if a woman loses her chip, she can recall all of her information through the database through her thumbprint.
What about the days when the technology goes down or a devastating hurricane wipes out all the satellites?
So that's a good question. You don't need any internet connectivity during the visit itself. So as long as you have a phone and it's powered, so it does need to be powered, but you know, a lot of the new phones, that if we don't have too many applications on it and it's not on the internet, it should last for a while. Yes. So that's why we use NFC technology, because you don't need to have connectivity at the point of care. So at some point, you need connectivity to get paid, but you know, that usually happens at some point, and so like if there's a little bit of delay, everything's delayed anyways. But yeah.
I'm curious if you've looked at the data from the feedback that the mothers can provide back.
So we're still in, we've done the prototype and we've worked with it, but we don't have enough data on that yet. That's what our next step is. But we have done some focus groups with women to ask about what they're interested in, why they go to private facilities. Oh, sorry.
Question?
Yeah.
Well, just a little comment. Thank you very much. That was very interesting and quite exciting way to approach care with the card, and it's a simple little thing. You asked about additional messages around the breastfeeding, and I saw that you had some of the key messages that people hear a lot and mean nothing. So I was wondering if you looked at DHS data or some other qualitative research data in Liberia to see what are the barriers to exclusive breastfeeding. In other countries, particularly in Africa, a lot of times it's just water, that if they could not give the child water, exclusive breastfeeding rates would go up. So you may look at just like one key message or two, no water or no food, or if there's traditional practice of giving teas or herbs prior to the breast milk coming in, you just might tap those 1, 2, 3 messages.
Okay.
And the whole general thing about exclusive breastfeeding is good and all of that. That might help as a job aid.
So I think that's a good point. In Liberia, it's not sort of their big challenge, but I think it may have changed over the last few years, and so that's the thing to look at is like what is the key thing that may have changed, and also when we go to other countries, we'll look at that.
This is so inspiring, and I just want to like jump up and say, wow, brilliant. And I'm wondering how the Liberians are accepting of this, since it's not coming from, this model isn't coming from them, and how they see it and accept it.
That's a good question. My colleague, I'm sort of new to the project, but my colleague has been working in Liberia for many years, and this is really born out of what she saw there and talking to a lot of people. And so the government has been, one of the reasons why we went there, a lot of people have asked us why Liberia. There's a lot of other countries that are, have a national health insurance scheme. Try it out there. It's a little bit more developed. But we've had a lot of political will to engage with us. We met with the Minister of Health. She has since left, but the new Minister of Health was an owner of the first private facility that we met there. We were also advised by the former Minister of Health, and so we have had a lot of engagement with stakeholders on the ground to ask what they are interested in and what makes sense for them. So while we sort of came to them with the idea, it was based on feedback and conversations prior to that with them.
Thank you so much for the presentation. The providers that you have in your program, must they be part of a network, or is it any provider that a patient would go through?
So it would be an accredited participating provider. So first, they would have to be accredited by the local organization in Liberia, and then they'd have to agree to participate. So our idea is that we would negotiate with them a set price with the government. So it's not that anybody can charge anything. We would want to have a negotiation which actually helps all women get sort of a very clear and transparent price, and so they would have to agree.
It seems like during the Ebola crisis that occurred, there was a bit of a natural experiment in having women going to the private care facilities. Was there any data collection in terms of outcomes for some of the things that we're interested in?
So yes and no. They found that a lot of women went to the private facilities, and they continued to go after the crisis ended as long as there was a discount. So they know that if they're willing to pay some amount to go to the private facility. Our program, the idea is that they wouldn't pay anything at the beginning, that this would be funded exclusively. But we know that that's where they would want to go if they had a choice. And they do have better metrics than the public facilities. Now, that being said, they have a smaller number. So, but also data collection was a little bit of a challenge generally. So we have some.
Not because there isn't more to say, but because we do need to move on.
Well,
Thank
thanks.
you very much.
Love to continue the discussion.
Yes, and we will come.